I'm honored today to introduce Dr. Tara Naib for her grand rounds on perioperative cardiac assessment for non-cardiac surgery. Dr. Naib received her medical degree from Albert Einstein College of Medicine. She then went on to complete her internal medicine residency training at New York Presbyterian Weill Cornell Medical Center and her training in cardiology here at Mount Sinai. Dr. Naib currently serves as an assistant professor of cardiology here at Mount Sinai. A large focus of her practice is in the perioperative management of cardiovascular patients. In addition to her clinical pursuits, Dr. Naib has excelled as a clinician educator. Known for her endless patience, kindness, and phenomenal teaching skills, Dr. Naib is a clear favorite amongst the house staff. Having had the good fortune of personally working with Dr. Naib on multiple occasions, I can attest to the sheer joy she brings to the practice of medicine. Dr. Naib has and will continue to serve as a role model for how we practice medicine here at Mount Sinai. Without further ado, please join me in giving a warm welcome to Dr. Tara Naib.
Thank you for having me, and thank you, Matt, for the very kind introduction. I hope this is a very important topic, preoperative cardiac evaluation for non-cardiac surgery, as opposed to preoperative cardiac evaluation for cardiac surgery, which is also another topic in and of itself that I also spend a lot of time doing with the cardiothoracic surgeons on 7 West. Let's just get started here. I thought it would be very interesting to start with just a case, a sample case, and then we can kind of just go over all of the topics that I have scheduled for today. So this is my patient, Gigi. She's, at the time that I had her, this is about in December of 2015, she was an 89-year-old woman with a history of severe valvular aortic stenosis. For those of you who are familiar, the peak gradient with echocardiographic findings, the peak gradient was 41 millimeters of mercury with a peak continuous wave velocity of 3.2 meters per second and an aortic valve area of 0.8 centimeters squared by Doppler. So she did meet criteria for severe valvular aortic stenosis, but her gradients weren't really that severe, severe enough to warrant surgery in the absence of symptoms. For this 89-year-old woman, she was asymptomatic. She could work 20 city blocks at her own slow pace, but she could do it, never had any problems. She doesn't really take the subway, she usually walks or cabs. 1 month after the echo that I had just done, she had a mechanical fall. She slipped on some ice and she fractured her femur. She was over at Mount Sinai West, and the orthopedic surgeon called me asking about cardiac clearance and what to do about her and her valve in order to make her a safe candidate for surgery. So just bear this in mind. We'll get back to this at the very end of the talk. But before we really get into anything, what does cardiac clearance, or what does this mean? It's not really just about pre-operative clearance or just optimization before the surgery. I like to think of it more as perioperative management, which is management before, during, and after the surgery. And remember that once the patient's had surgery, your work isn't really done at the time of the surgery. Sometimes there's actually more work to do after the surgery to make sure that the patient is stable and prevents and you can avoiding adverse events. So we really have to look at the combined surgical risk of the procedure at hand and also the clinical risk of the patient. And what risk are we talking about? Well, we define it as MACE, which is defined as major adverse cardiac event. And these would be considered to be perioperative MIs, for example, heart failure, ventricular fibrillation, cardiac arrest, complete heart block, and even cardiac death. So these are the events that we're trying to avoid. There were 2 guidelines that came out in 2014. One was by the ACC-AHA, and the other one was by the European Society of Cardiology. They're very similar in a lot of respects. I will say that in the European guidelines tend to be a little bit more supportive of getting things like biomarkers. They're a little bit more liberal in their assessment of whether or not to get echoes, for example, biomarkers. We tend to be a little bit more conservative in how we manage and assess these patients. Always ask yourself the question when you're evaluating a patient preoperatively. And the question that you should ask is, how would I manage this patient in the absence of the surgical procedure in question? This is very, very important. You shouldn't be getting stress tests on patients. You shouldn't be performing catheterizations on patients just because they're about to have surgery. There should be some other clinical indication for undergoing these procedures. And so if you wouldn't do a procedure on a patient in the absence of the surgery, with few exceptions, you really shouldn't be doing the procedure just because they're having the surgery. So this is a long list of surgical risks, categorizing surgical risks for various procedures. We can categorize them in terms of low risk, where there's a less than 1% chance of MACE, high risk, where there's a greater than 5% chance of MACE, and everything in between. It is a long list, but I did want to highlight several procedures. Specifically, some of the procedures that you are managing a patient for, such as perhaps a laparoscopic appendectomy or cholecystectomy, which may be considered low to moderate risk, remember that the patients are also consenting to a possible open surgery. And so when you are assessing the patients for these kinds of surgeries, remember that you should probably be assessing them as if they were to have an open surgery if that is an option for the patient. The same thing will go for endovascular aneurysm repairs. Those are usually considered intermediate risk, but the patients are also consenting for, and there's always a possibility that you'll have to open that patient up. So it's better to assess the patient as if they're going to have the worst case scenario or the higher risk surgery, because you probably won't go wrong that way. Other orthopedic surgery is considered an intermediate risk surgery. There's usually a lot of blood loss that can be involved in these surgeries, and that's something that you should bear in mind. And then two surgeries that we see a lot of are renal transplants and liver transplants. Kidney transplants being considered intermediate risk, and liver transplants, because of the large amount of fluid shifts involved, are considered high-risk surgeries. And then remember that not all abdominal surgeries are considered intermediate risk. I think that that's sometimes the teaching, but some abdominal surgeries are considered to be intermediate risk. But once you get into the duodenal-pancreatic surgeries, bile ducts, liver resections, bowel repairs, total colectomies, those tend to be higher-risk surgeries, okay? So let's now look a little bit at the clinical risk factors for these patients. So some of them are pretty obvious: coronary artery disease. And how do we determine this? So let's talk about a history of an MI. History of MI is definitely predictive of MACE, which makes sense. And we define a recent MI as having had an MI within 6 months. If you have a patient who's had a myocardial infarction and needs surgery, try to delay the surgery for at least 60 days. Let things cool off. Let the heart recover from the heart attack, and then try and proceed with the surgery. It's not always possible if the surgery is an urgent surgery, but if you can, try to wait for at least a couple of months after the heart attack. Heart failure. There is definitely evidence, and the absolute mortality rate for patients with an ejection fraction of less than 30% is much higher than for patients without it. But remember that we're seeing a lot of patients now with HFpEF, which is heart failure with preserved ejection fractions. So patients who manifest heart failure symptoms but with an ejection fraction greater than 40%. And those patients, when compared to, also have an increased mortality versus those patients without HFpEF. Remember that if you see a patient who's in decompensated heart failure, it's not a good idea to proceed with surgery. You may even need to delay the surgery if the patient's decompensated. You want to make sure that they come out of the OR in better shape than they were going in. Cardiomyopathies. So there are a few cardiomyopathies that I just wanted to point out. One is restrictive cardiomyopathies, and these are important because more in terms of how you manage these patients. So it's important to know what kind of cardiomyopathy a patient has. For example, if a patient has a restrictive cardiomyopathy, for example, maybe amyloid, sarcoid, hemochromatosis, they're going to be very preload and heart rate dependent. Same thing applies for patients with hypertrophic obstructive cardiomyopathy. And in these kinds of patients, you want to avoid overdiuresis. You want to avoid the use of inotropes if at all possible, because you will adversely affect their hemodynamics. And this is something that you'll need to maybe talk to the surgeons and the anesthesiologists about before the surgery. Maybe you want to get cardiac anesthesia involved because they're more used to kind of taking care of these complex patients. Patients with arrhythmogenic right ventricular dysplasia or right ventricular cardiomyopathy. Do they need an ICD before the surgery? You need to really monitor these patients for arrhythmias, most specifically VT. And then we have A lot of high-risk patients who the obstetricians are seeing. Peripartum cardiomyopathy is definitely something that we see a lot of. How are you going to deliver this patient? Does this patient need ECMO? Does this patient need mechanical support? Does this patient need a transplant? These are things that you need to consider when dealing with these patients. Let's take a little step and move on to valvular heart disease. So just remember that left-sided valves sometimes will create more of a problem than right-sided valves, and stenoses create more of a problem than regurgitation. So for example, mitral stenosis is probably going to be the most problematic valvular disease that you're going to have versus tricuspid regurg. Sometimes it's going to be an issue as well, but may not be as much of an issue as something like mitral stenosis. So you want to avoid in these patients hemodynamics that are going to cause hypotension, tachycardia, volume shifts, administration of IV fluids. You need to be very, very careful with these things. If you have a patient with aortic stenosis, how are you going to manage that patient? Does the patient need a BAV before the procedure? Do they need a TAVR? Do they need to get a bioprosthetic or a mechanical aortic valve replacement? For mitral stenosis, do you need to balloon that valve as well, especially if it's a rheumatic patient? And especially in mitral stenosis, do you need to have an invasive hemodynamic monitor? Do you need to put in a Swan-Ganz or a PA catheter so that you can actually measure both the left-sided and the right-sided pressures intraoperatively and postoperatively? Do you need to get an echo on these patients? If you have a patient with known valvular disease who hasn't had an echo recently, it may be a good idea just to get an echo to make sure that the patient's moderate aortic stenosis is now not severe aortic stenosis. And if you need to, we're always open to having the patient come into the CCU or the CICU or the ICU preoperatively and postoperatively if we need to manage these patients more invasively or if we need to monitor these patients more closely. We're very, very open to that. Dr. Gidwani is very good about that. Let's just take a little step, just look specifically for aortic stenosis. We've talked a little bit about this already, but I did just want to emphasize that you need to know that the patient meets guideline indications for aortic valve surgery or intervention before you actually go around doing procedures on these patients. So if you decided that the patient did not need an intervention for their valve and now they need surgery, you probably shouldn't jump to do the intervention that you already decided that you weren't going to do, okay? And as I said, with mitral stenosis, you really need to be aware that they are very preload dependent. You need to avoid tachycardia. They will not tolerate atrial fibrillation very well, and they may not tolerate hypotension very well. And in these patients, as I emphasized before, you probably want to put a PA catheter into this patient so that you can measure the right atrial pressures and the wedge pressure, which is also a measure of the left atrial pressure. Risk models. It's advisable to use the risk models to guide your management of these patients. There are three that I think are interesting, and you can use any one you want. The RCRI, which is a Revised Cardiac Risk Index, is something that you should be familiar with, and you can certainly familiarize yourself with. It's the most commonly used risk model for perioperative assessment. Then there's also the American College of Surgeons, the National Surgical Quality Improvement Program, and it's interesting because they include things like age, ASA class, and also the functional status, which I think is actually very important. There is another one, which is the NSQIP, but in addition, the MICA stands for MI or cardiac arrest. And this has an even more extensive list of the type of surgery that a patient's having, and that actually goes into their risk assessment. So let's just turn to the RCRI, since that's the one that we use the most. It is very widely used. It's very well validated. It's been validated many times over the last 15 years. I will say, however, that it's not as good for evaluating patients for vascular surgery, which we consider to be very, in general, high-risk surgeries. But these are the criteria that we use to measure the RCRI risk score. So these are all counted equally, and there are 6 factors. One is high-risk surgery. There's a history of ischemic heart disease, whether that's an MI, a positive stress test, chest pain requiring nitrate treatment, and an EKG with pathologic Q waves. A history of heart failure, a history of a stroke, insulin-dependent diabetes, which we consider to be a coronary artery disease equivalent, and a creatinine greater than 2, or a GFR less than 50. And there is data to show that patients with 0 risk factors with 1 risk factor have an incidence of MACE of about 1%, and patients who have a score of more than 3, or greater than or equal to 3, have a risk of MACE of over 5%. So it actually does matter, and 5% is a big percentage when you think about MACE in these procedures. And MACE they defined over here as requiring cardiac catheterization, so basically ACS, non-fatal MI, non-fatal cardiac arrest, pulmonary edema, complete heart block. This is what they describe. This is how they define the major cardiac complications. I will say that with these risk factors, they're important to look at, and it is very, very important to use them, but don't hold your hat, don't hang your hat on them. The relevance at this point, given that these were developed over 15 years ago, things have changed. We have better and safer surgical techniques. We have different anesthetic agents. And we're seeing much more demand ischemia than type 1 MIs. We're able to treat coronary disease much more aggressively with the use of statins, for example. And this has kind of changed how people are having heart attacks postoperatively. I think we're also operating on sicker patients. And so if you're seeing more demand ischemia, it's a different beast than an acute coronary syndrome from plaque rupture. Risk stratifying the patient. So low-risk patients, that seems kind of easy, right? Just proceed to surgery, don't further test them. Oftentimes, even for cataract surgery, the ophthalmologist, not necessarily from here, will require an EKG. It's an easy enough test to get, and I'm not going to argue against getting an EKG, but it's really not required, and there's no evidence to show that it actually matters. Very high-risk patients, you got to stabilize the patient first, right? If you think that the patient's going to die or is going to have a terrible outcome from the surgery, no surgeon wants that. Okay, and so if you talk to the surgeon and say, I understand that this surgery is urgent, but I need a day to stabilize the patient, they will agree to it, okay? If they've had a recent MI, if they're having unstable angina, if you have decompensated heart failure, the 2 most important physical exam findings, especially for the interns, are going to be JVD, the elevated JVD in the presence of an S3, okay? If you're having high-grade arrhythmias, maybe you need to talk to the electrophysiologist about putting in, or the anesthesiologist about putting in a transvenous pacer in the patient to prevent heart block intraoperatively and postoperatively. And especially if they have hemodynamically significant valvular disease, you want to make sure that you are sending them to surgery in the best possible situation. The moderate risk gets a little bit more interesting. And what you need to do is really assess their functional capacity. We talk about at least 4 METs, METs being metabolic equivalents. And what I usually like to do is see if they can do at least 4 METs. And so if a patient can climb...
Person to join the conference.
Hi. So this is nice. So if they're able to climb at least 2 flights of stairs or walk at least 4 blocks, then I would consider that to be more than 4 METs. So if they can climb a flight of stairs, if they can walk 3 blocks, that's about 4 METs. If they can do a little bit more than that, I consider that at least 4 to 10 METs. And if you can do more than 10 METs, go for a run, bike in Central Park, do some more strenuous exercise. That's considered to be excellent in terms of prognosis. A lot of the patients, though, aren't able to walk for various reasons. Either they're having hip surgery, or they've had a bad hip or a bad knee, or they have vascular disease and they can't walk, and you can't really assess whether or not they can do 4 METs. The recommendation is for pharmacological testing. And you can either do that, so I guess stress test is a whole other talk in and of itself, but just remember with pharmacologic stress testing, so these are patients who you know cannot walk, and you are not really able to see if they can actually achieve these 4 METs that you would need to clear the patient for the surgery. You can do a dobutamine stress echo, which is considered to be physiologically very similar to the stress of surgery, or you can even do a myocardial perfusion imaging study. And this is more commonly used. It's a little bit more easily reproducible, a little bit less operator dependent. Either one is fine. Okay, so you just get the test that you're the most comfortable with, or maybe that the cardiologist is the most comfortable with, and you just go for it. I don't know if this projects very well, but this is the algorithm that's in the guidelines. And basically all you really need to know is that it's a class 2A indication down there to do pharmacologic stress testing if you don't know the patient's functional capacity or if it's poor. And if the patient has excellent functional capacity, more than 10 meds, you don't really need to prove that. You know that they can bike in Central Park, and you just go ahead and proceed to surgery. And even if it's between 4 and 10 meds, for the most part, although it's a class 2B indication as opposed to a class 2A with a greater than 10 meds, you can certainly proceed to surgery. So functional capacity actually matters, and it makes a difference. EKGs. I did mention EKGs. They can be useful. I'm not saying they're not useful. In patients with cardiovascular disease, with arrhythmias, with known structural heart disease, you can certainly get a baseline EKG before the surgery. Otherwise, it's really not that helpful. And there really is no consistent evidence that EKG abnormalities are prognostic of outcomes. The ACC-AHA guidelines do stress that we really don't know if that EKGs really haven't been established as an effective screening tool for postoperative MI in these high-risk patients. This differs a little bit from the European guidelines, which actually are more supportive of getting postoperative and perioperative EKGs. And the level of evidence for that is a B. Echocardiograms. As I mentioned before, there's certainly an association between the left ventricular ejection fraction and perioperative events, especially if the ejection fraction is less than 30%. But that's not to say that we should be screening every patient who's pre-op with an echo. By all means, do get the echocardiogram if there's a suspicion for a cardiomyopathy, for valvular heart disease. If in your history you find that the patient has some unexplained or maybe worsening dyspnea, especially if it's on exertion. On physical exam, if you find an elevated JVD, an S3, displaced PMI, maybe an RV heave, the presence of a murmur, the absence of an S2, a loud P2, which might be suggestive of pulmonary hypertension, pulmonary edema, maybe you feel a pulsatile liver, maybe the patient has severe TR, a lower extremity edema, maybe they're in right-sided heart failure. By all means, definitely get the echo to see what's going on with the patient before you proceed to surgery. But it's a class 3 recommendation, which means don't do it. Routine preoperative evaluation of LV function is not recommended by the ACC-AHA guidelines, okay, as routine. But by all means, if you suspect that there's anything going on, certainly have a low threshold to get it. And if you need it urgently, we can help. Perioperative beta blocker therapy. There's a lot of controversy. Don Poldermans, who back in, I think, 1999 started to publish 5 studies out of Erasmus University in the Netherlands. They were called the DECREASE studies, specifically to beta blockers with the DECREASE 1 and the DECREASE 4 trials. And that was used to heavily weigh, the evidence from that was used to heavily weigh our decision to use beta blockers perioperatively and to even start them in the immediate preoperative setting. Unfortunately, later on it was discovered that this data not only was not reproducible, but that it was also falsified. And so the guidelines have really gone back, and in 2014 there was a supplement to this, using other trials, but also removing the DECREASE study from their guidelines. So the pros of giving perioperative beta blockers are that you do have a reduction in non-fatal MI, especially in patients who are at high risk for a myocardial infarction. But you do that at the cost of strokes, even death, hypotension, and bradycardia. So it doesn't really necessarily mean that giving somebody a beta blocker, even though you're going to prevent an MI, means that you're going to prevent the patient from having a terrible outcome like a stroke or even death. So what do we do with the beta blockers? Keep it simple. If they're already on a beta blocker, it's a class 1 indication, just continue it, okay? Unless there's a reason to stop it, the patient's in decompensated heart failure, something else is going on. But if they come in and they're already on a beta blocker, they've had a history of MI, they have a stent, they've had a CABG, just keep them on it. If you think that the patient is intermediate or high risk for MI based on your pre-op testing, if they have more than 3 or more RCRI risk factors, or then you might want to consider starting it. Don't start it on the day of the surgery. Maybe give it a little bit of time. If you have the luxury of seeing the patient as an outpatient before a scheduled surgery, maybe start it then. Wait a couple of weeks, see how they do. They say that you need at least 2 to 7 days, so you really want to see how the patient really responds to the beta blocker, and I think the more time before the surgery to be on it, the better. If it's really, really too soon, don't do it. Don't start it the day off because you think the patient's going to have an MI. You never know how they're going to respond to the beta blocker, especially in the setting of the anesthesia, and your good intentions may not pan out. Remember that for patients with systolic heart failure, you have a patient who has a new, well-compensated patient, but their ejection fraction, you heard a murmur, they have severe MR, their ejection fraction with a severe MR is 40%, but they're well compensated. You may want to put that patient on goal-directed medical therapy, which includes the use of a beta blocker. You don't need to do that right before the surgery, right? This is for long-term, this is to help the patient long-term. So just because they have a new diagnosis of a cardiomyopathy and you really want to apply your goal-directed medical therapies to the patient doesn't mean that now is the time to do it, okay? So by all means, when the patient's stable after the surgery, you can see them either at the end of their inpatient stay or even as an outpatient and start these therapies, but it's not an emergency to start this, and it's not going to help the patient over the next day or two. Statins, HMG-CoAs, reductase inhibitors, if they're already going to statin, continue it. This is one of the medications that I think is reasonable to start before a surgery. I think that it's one of the medicines that's always sometimes forgotten to be started even after the surgery. And if you're having an MI, it's nice to have the statin on board. It really doesn't have any hemodynamic effects on the patient. So personally, if I think a patient is of a high enough RCRI risk score, I think it is, I agree, well, it's good that I agree with the guidelines, but it is reasonable to start it prior to elevated risk procedures, so you think the patient might be at high risk for having an MI, or prior to vascular surgery, which I would consider kind of a coronary artery disease equivalent, because if you have vascular disease, you probably have some coronary disease too. ACE inhibitors, in general, I think it's okay to continue them, but some of the surgeons and some of the anesthesiologists are a little concerned with the vasoplegia, so it's okay to hold them, especially if that's the comfort of the proceduralists and the anesthesiologists. Biomarkers. I think this is a very interesting topic. There is more and more data that's coming out supporting the use of biomarkers. It hasn't really made it into the guidelines, into the ACC-AHA guidelines, but it is in the European guidelines, and they are proponents of getting BNPs and troponins perioperatively. So there is data to show that preoperative BNPs and postoperative BNPs are associated with an increased risk of cardiac events at the 30-day mark. And these events are death, cardiac death, and non-fatal MI. So these are pretty serious cardiac events. It may be helpful in managing perioperative heart failure, but I think if you have a good enough physical exam, you don't really need the BNP to show that your patient's overloaded and needs diuresis. There is no evidence to suggest that adjusting the management just to target the number, so getting a patient who has a BNP of 1,000, getting them to a BNP of 500, that's necessarily going to improve the outcomes in the absence of stabilizing the patient, right? So if a patient's already euvolemic, they have a BNP of 700, that's kind of their baseline for what it's worth. Trying to target that and trying to change that with medications and with more diuresis is really not going to improve your outcomes, okay? So use your physical exam to guide you and not the BNP. By all means, if you want to get a BNP before the surgery to kind of see where the patient is, and if you think it's going to help you with the management afterwards, by all means you can get it. Personally, I haven't really found it to be very helpful. Troponins. Troponins, as you know, are a measure of myocardial injury, and they do carry prognostic value. There were 2 very large studies, the VISION study and the POISE trial, and basically they showed that perioperative MI or elevated troponin levels, it was associated with an increased 30-day mortality. And this was just based on elevated levels of troponins. It wasn't necessarily based on ACS. So not all elevated troponins are going to be due to ACS, right? Sometimes your elevated troponins are going to be from a PE, from sepsis, AFib, CKD, and some patients just have an elevated troponin because they have some ongoing myocardial damage from their cardiac disease. And so if you are thinking about getting troponins postoperatively, and I don't necessarily recommend that you do it, but if you want to, probably a good idea to get a troponin preoperatively. But remember, if you get a troponin preoperatively in a patient who has a chronically elevated troponin, alarm bells may sound because now you're sending a patient with an elevated troponin. Anesthesia is not going to like it. A surgeon will not like it. And so just be careful when you're getting data because sometimes information is not a good thing. In general, I have found that unless I think that a patient has ACS, by all means, if you think a patient's having a heart attack, please get the troponin, the MB, the EKG, and everything. But in the absence of any of these, I personally have found that it causes a little bit more drama than it does really help the patient. And if you know that a patient has coronary disease, if you know they're a high-risk patient, you need to be following those patients after the surgery and not just looking at lab values, okay? So go and see the patient after the surgery. That's going to be a lot more helpful than asking the nurse to draw troponin and kind of following that. And the guidelines, the ACC-AHA guidelines do say that also getting troponin levels post-operatively is of uncertain utility in the absence of any clinical suspicion of NMI, and that's a class 2B level of evidence B, I think, indication. The European guidelines are a little bit more liberal with this, and they are a little bit more proponents of getting biomarkers in general. Moving on to DAPT. This is good music for DAPT. So what do we do for, it was a good segue. What do we do from thrombotic risk versus hemorrhagic risk? Okay, we have to really weigh this, right? This is what we're doing. The risk of bleeding versus the risk of stent thrombosis. Coronary stents. Ideally, you should wait for about 6 months before you interrupt dual antiplatelet therapy, whether it's a bare metal stent or a drug-eluting stent. We can't always do this, okay? It's okay to discontinue or to interrupt dual antiplatelet therapy if you are after 30 days from a bare metal stent or if you're after 6 months from a drug-eluting stent. If you need to operate on a patient between 3 and 6 months of having a drug-eluting stent, it's okay to do it. It's a class 2B indication. And just note that this has actually changed from the previous guidelines, which had drug-eluting stents class 1 at 12 months and a class 2B at 6 months. The newer generation stents are a little bit easier to manage in terms of the time that you need to be on dual antiplatelet therapy before you can safely interrupt them. If you need to operate on a patient urgently, more urgently than within the 30 days, it's a class 3 to stop the DAPT at less than 30 days, and it's a class 3, which means don't do it if you are stopping DAPT or if you're interrupting DAPT at less than 3 months after a drug-eluting stent. So if you need to do a surgery that's more urgent, you can certainly do balloon angioplasty. Basically what they do is they balloon open the lesion. They don't put a stent in. You're on aspirin Plavix for about 2 weeks, or aspirin and another P2Y12 inhibitor for about 2 weeks, and then you can safely operate on the patient, okay? And then maybe they'll bring the patient back after the operation and actually put the stent in if they need to. After stent implantation, it is ideal to try to wait for at least 4 to 6 weeks. And if you really can't wait for 4 to 6 weeks and they already have a stent, then see if they can operate on the aspirin Plavix. Sometimes a surgeon, you'd be surprised as to when you explain the situation and you communicate with the surgeons and the anesthesiologists that they may actually be amenable to doing procedures on dual antiplatelet therapy if they understand the situation at hand and if they know the risks associated with interrupting this. The other thing that I wanted to point out is talk to the interventionalist. Some of the interventionalists all the interventionalists are going to be very receptive to talking to you about whether or not it's safe to interrupt this antiplatelet therapy, okay? And so if there's any question, talk to the person who put the stent in. They know how these stents work, they're very familiar with them, they have experience with interrupting the antiplatelet therapy, and so use their expertise. If you do need to discontinue the dual antiplatelet therapy, it's advisable to continue the aspirin. You can stop the P2Y12 inhibitor. The ones that we use most commonly are prasugrel or Efient, ticagrelor, Brilinta, and clopidogrel or Plavix. The Brilinta and the Plavix, it's okay to discontinue them for about 5 days prior. The Efient, you need about a week to discontinue it just because of the bleeding risk and the half-life. Resume it as soon as possible, usually when hemostasis can be achieved, which is going to be probably within 1 to 3 days after the surgery. And because you've discontinued it, when you start it, you should really start it up with a loading dose to make sure that the patient is well protected as soon as possible. If your patient is of very high thrombotic risk, meaning that you think that the patient's stent may thrombose by discontinuing the DAPT, they have to have the surgery. There is no choice. They already have a stent in. And it's a surgery that if they don't have, could really affect them adversely. It's okay to bridge them. So you can bridge them with a low molecule 2B3A inhibitors, which we don't do a lot over here, but for example, terifibam and eptifibatide can be used. More commonly, we can use cangrelor, okay? With both of these, the onset of action is, when cangrelor, by the way, is another P2Y12 inhibitor. That's IV. The onset of action for both of these classes is immediate. You can initiate it within 72 hours of stopping the oral P2Y12 inhibitor, and you can continue it up to about 1 to 6 hours before the OR start time. And once the operation is finished, and the patient is unable to take oral medications, you can actually resume it within 4 to 6 hours postoperatively. So it can be actually very useful to bridge these high-risk patients. And I just wanted to talk a little bit about cangrelor, which we will use here if we need to. I think it's the preferred strategy. I think the cath lab likes this too. It is P2Y12 specific. Its half-life is about 3 to 5 minutes as opposed to 2 hours with the 2B3A inhibitors. The onset of action is just about an hour versus 4 to 6 hours with the 2B3A inhibitors. Anticoagulation management. The atrial fibrillation is the most common reason for patients being on anticoagulation, and so you're going to encounter this a lot in your perioperative assessment of patients. How long should we hold the anticoagulation? What are the anticoagulants that we typically use? So we can use warfarin, or we can use some of the direct oral anticoagulants. Warfarin, you typically will hold for about 5 days before the surgery. And then with the other ones, the dabigatran, the rivaroxaban, the apixaban, and not that we're seeing much of it, but also adoxaban, you really want to, for the most part, skip about 4 doses, right? So dabigatran you hold for 2 days because it's a BID drug. The rivaroxaban, I apologize, you hold for about 4 days because you want to skip 4 doses. And the apixaban, you'll skip 4 doses, so you want to hold it for about 2 days. When hemostasis is secure, you want to just resume it. And you resume it without a loading dose, you just restart it, okay? If they're a high bleeding risk, you might want to wait a couple of days. If they're a low enough bleeding risk, you might even want to start it a day after the surgery or even the evening of, okay? You have to understand the risks of the actual procedure, right? So the bleeding risk from the procedure matters. The mode of anesthesia delivery matters as well. If a neurosurgeon is going to be, if the anesthesiologist is going to be performing anesthesia intrathecally or administering anesthesia intrathecally, maybe they'll want to hold it for more than just 4 doses. That's okay, because the bleeding risk associated with having a bleed into your spine could be devastating. And if the anesthesiologist wants to hold it for 6 doses or 8 doses as opposed to 4, and the patient's low enough risk, it's okay. Okay, so work with the anesthesiologist and work with the surgeons as well. Also remember that if a patient has a very high CHA2DS2-VASc score, those are the patients who you might want to consider bridging, okay? So hold the anticoagulation. If you need to bridge the patient with Lovenox, you can certainly do that. And in some situations, not necessarily for AFib, you may want to bring them into the hospital to bridge with a heparin drip. And that's a good segue into the question of should we bridge our patients? And how should we bridge our patients? Typically, how do we do it? Typically, we'll do it either with Lovenox, a low molecular weight heparin. We will stop it 24 hours before the procedure. You can also put the patient on a heparin drip and stop the heparin drip about 4 hours before the procedure. The BRIDGE trial was a very large randomized double-blind placebo-controlled trial that actually looked at discontinuation of warfarin and bridging with warfarin. And bridging anticoagulation, rather. So warfarin was stopped at about day -5. And then placebo versus deltaparin was started at day -3. And they found in this study that the discontinuation of warfarin without a bridge was non-inferior to discontinuing it with a bridge. I will say that for the most part, there were very few patients in this study who had CHAD scores of 5 or 6, okay? About 1/3 of patients had, so the majority, about 2/3 of the patients had a CHAD score of less than 3, so of 0, 1, or 2. And only about 1/3 of that population in the study had a CHAD score of more than 3, okay? So very few with scores of 5 or 6. So if you have a patient with a score of 5 or 6, I don't think that the bridge trial really does apply to these patients. And if you think that a patient who's had a stroke, who has CHF, who has hypertension, who's older, and who has diabetes, that patient maybe you don't want to apply the bridge trial to. Maybe you do want to bridge that patient, okay? So just remember what the population. Remember when you apply studies, who was studied in these patients and really what the population is, okay, before you extrapolate from the data. There was a periprocedural anticoagulation path. There's a very good article that came out last year that was published in JACC looking at this. And it's a little bit complicated, but I thought it was a nice table just to show, and it really looks at all the different scenarios for patients in terms of the surgical risk, the patient risk, should you bridge, should you not bridge, and I just thought it was a nice way, and you can certainly look it up. It was published last year in JACC, looking at a nice way to kind of think about your patients in terms of making a decision of whether or not to bridge. Mechanical prosthetic valves. Mechanical prosthetic valves do carry a risk of valve thrombosis. Lower flow states, where there is less flow or lower velocities going through these valves, there's going to be a risk of more thrombosis. So, for example, a mechanical valve a mechanical tricuspid valve is going to be extremely thrombogenic, and a mechanical aortic valve is going to be the least thrombogenic of the mechanical valves. And since most of the patients who we see have left-sided mechanical valves, remember that mechanical mitral valves are definitely going to be more thrombogenic than mechanical aortic valves. You can use low molecular weight heparin in mechanical mitral valves, but if you do think that a patient is high risk, if they've already had valve thrombosis, if they've already had strokes, and you think that they're really at risk for having valve thrombosis, you might want to admit the patient and start them on unfractionated heparin in the hospital for a few days prior to the procedure. If you think that they're low enough risk, you can get away with using low molecular weight heparin, but mechanical mitral valves make me a little bit nervous. What about mechanical aortic valves? If you have no other risk factors for valve thrombosis, if you don't have any AFib, you don't have any heart failure, you don't have a history of a stroke, you don't need to bridge with a low molecular weight heparin or unfractionated heparin. If you do have additional risk factors, these are the patients who it may be a good idea to also bridge. Okay. How am I doing with time? Good. Okay. Just a couple of minutes on cardiovascular implantable electronic devices. These are pacemakers and ICDs. The main issue from surgery is going to be from monopolar electrosurgery, which is what's used most of the time, and it's used for both coagulation and dissection. Usually it's for surgeries that are using this monopolar electrosurgery above the umbilicus, so closer to the actual pacemaker or ICD. Why do we care? So the noise from the electrosurgery may cause the pacemaker to oversense. So it may think that the patient's be tachycardic at a rate of 150 when it actually is bradycardic at 20, and the pacemaker may inhibit actually pacing. The ATP, the anti-tachycardia pacing function of the ICDs may either be inhibited, or maybe they can falsely detect arrhythmias and shock the patient inappropriately. So what can we do surgically? So the surgeons know and the anesthesiologists know that if you use short bursts, less than 5 seconds of the monopolar electrosurgery, that'll work. If you can use bipolar surgery, but that's not always going to be an option for a lot of these surgeries. And sometimes what you can do is you can position the return of the electrode so it's actually away from, most of the pacemakers and ICDs is going to be left-sided. Sometimes you'll see them on the right side. But if you can try to position them away from the path of the pacemaker or the ICD, that'll also help reduce the risk of inappropriate sensing. So what do we recommend? You can put a magnet on the patient. So what is a magnet? It really looks like a donut. So it's literally a heavy circle. They're usually blue, and it's a 90 Gauss magnet. What does it do? It suspends arrhythmia detection. It protects from inappropriate sensing. And in a pacemaker, what it's going to do, it's going to put the patient in VOO mode. So it's going to pace the patient at, for example, 60 beats a minute no matter what. okay? That's going to be safe in the short term to use in surgery. The patient's under monitor. After the surgery, though, it's not a good idea to leave the magnet on the patient because you can expose the patient to the risk of RNT and ventricular fibrillation, type VT, VFib arrests. So you just need to know that for the short term, it's probably okay as long as the patient's being monitored. But if it's asynchronously pacing and the patient has an underlying rhythm, you may run the risk of having an RNT phenomenon. With the ICDs, all it will do is suspend the tachyarrhythmia detections, and it will inhibit anti-tachycardia therapies and shocks. So it will not revert to asynchronous pacing. So if you have a patient who has an ICD who is also pacemaker dependent, do not put a magnet on the patient. That patient will need an ICD interrogation, and the settings will need to be changed manually by the electrophysiology service, and then changed back when they're done. Okay, so this patient, Gigi, so this was a couple of years ago, 89-year-old woman, as you recall, severe aortic stenosis that I didn't think required surgery, and now has a femur fracture. So things to consider. As we said, we'd already decided before that she didn't need an intervention before the hip surgery. So just because she needs hip surgery now doesn't necessarily mean that she has to have an intervention. And if she is going to go for surgery, so remember that this is not just about preoperative clearance. It's not a yes-no kind of binary decision, should she be operated or not. Once you've made the decision to operate, you actually have the hard work coming up. So you need to be very vigilant about blood loss in her, right? So someone like her who loses 2 units of blood, she's going to need that blood for that valve, okay? So don't let her hemoglobin drip down to 7. If she had a hemoglobin of 11 and she drops down to 8, you may want to give her a unit or 2 of blood, okay? These are different situations from your septic patients, from your MICU patients. How much IV fluids did the patient get? You need to be very vigilant about that. Not only that, but did they lose, if they've lost blood and they have IV fluids, are they hypotensive? What's their hemodynamic situation? So the post and the perioperative care for this patient is going to be critical, okay? So the easy decision to make was to say, okay, let her have the surgery, but all the work is going to come afterwards. And that's where really being a good internist, a good cardiologist is really going to come into play. So she did undergo intramedullary nailing of her right pertrochanteric femur fracture, and that was December of 2015. We decided to involve cardiac anesthesia. She did well. She had very little perioperative blood loss. She didn't receive an excessive amount of IV fluids. Her blood pressure was maintained throughout the surgery and postoperatively, and she actually did very well. I last saw her, she's due for a visit with me now, but I last saw her in December of 2017. She was still asymptomatic. I did another echo. The velocities are still the same across the valve, and she's still walking her 20 blocks, so she's doing just fine. This was another case, and I'll be 1 minute because I know that I want a couple of minutes to answer questions. This woman came in from another hospital to the vascular surgery service. She has a history of hypertension, hyperlipidemia. They found on imaging for another reason, she had abdominal pain, lots of really, really bad aneurysms, okay? Her descending thoracic aorta was 7.1 centimeters, looked like it was about to burst. The abdominal aorta was 6.1 centimeters at the level of the bifurcation. So first things first, she needed a TEVAR, which is a thoracic endovascular aortic aneurysm repair. Remember that we consider these to be intermediate risk, but there's always a risk that this patient's going to have an open surgery, and that's a very high risk, okay? So you have to assess this patient as if they're going to have an open surgery of their descending aorta, descending thoracic aorta. It's scheduled for tomorrow. They're not going to change, and it's first case. That is non-negotiable, okay? You know how it is. It's 12:30 in the afternoon. The patient just ate a delicious lunch, and she cannot get a stress test today. You have to fast the patient for 4 hours, okay? So it's not happening. So what else can you do for this patient? This is where I think thinking a little bit outside the box might be useful. So this 81-year-old woman is going semi-urgently for TEVAR tomorrow, okay? What do you want to make sure? You really want to make sure in this kind of a situation that she's not going to have left main or proximal LAD disease, right? You can easily do that. You can get a CTA, her cranium was fine, surprisingly, or you can do a cardiac catheterization on the patient just to take a look, okay? If she doesn't have left main proximal LAD disease, you're probably going to be okay just letting her go, okay, without doing a stress test, without anything else. She had some obstructive RCA and OM disease. We ended up doing a CTA on her. Her left main and LAD had some disease, but it was non-obstructive, and we didn't think that the RCA and OM disease were really needed intervention before the surgery. And she actually underwent the TEVAR and did just fine. Okay? It was successful, my goodness. So that's my talk. If you have any questions, I'm happy to take them.
I'd like to thank Dr. Naib not only for a terrific overview, but also for her equanimity under fire when she was interrupted. This is open for any questions.
In the old days, we would say your lecture was terrific and it was a tour de force, so thank you.
Oh, thank you.
I have a question.
Yes, sir.
How do you look at the age of the surgeons in these procedures? And what about the experience of each hospital with the procedure that's chosen?
That's a very fair question, especially as Mount Sinai is expanding into a lot of different hospitals. Experience, there's no substitute for experience, as Dr. Niebart says. And for surgeons, I usually shake their hands and see if they have a steady hand. And if they have a firm handshake, I'm usually pretty confident. Yes, sir.
So I also think that it was a comprehensive and good lecture.
Thank you.
And so I'll go to a different question. I am told that a patient such as the first patient clearly has been followed by a Mount Sinai cardiologist, but when they come to be admitted, they don't accept what that cardiologist writes in terms of clearance. They have to get somebody who's a hospitalist to give the clearance. Is this correct? And is there evidence that it's helpful that way?
So I'm not sure if what you're referring to is the POMA, which is a preoperative medical assessment. And that seems to be a requirement for surgery. I think it's mandated by, I don't know, Medicare. I'm not sure. But that seems to be something that's mandated, that the hospital is mandated and obligated to do before a patient goes for surgery. Oftentimes what I do like to do is work with the internist, because there's a lot more just to the heart preoperatively and perioperatively. And so what I'll do is I'll usually work with the hospitalist or the internist, and they can focus more on the other non-cardiac issues that the patient has, and I'll focus on the cardiac issues. It's always good. So this patient actually was a patient of one of our older and more experienced physicians who I was helping take care of, and so it did help that somebody with a lot more gray hair than I do was also giving advice to the anesthesiologist and to the surgeons. And so I never mind getting a second opinion if it's needed. I will say that especially for certain procedures like vascular procedures, a lot of the surgeons will want a stress test before. You have to kind of pick your battles. It's a stress test. If they really want it, it's okay. And I try to work with the surgeons and with the anesthesiologist, because at the end of the day, they're the ones taking on the risk of the surgery, and I'm just there to help them. And so if it's helpful to them, even if it's not helpful or indicated for me to necessarily do preoperative ischemic testing, I'll just do it. It's okay. And then I'll deal with the results as and when they come. You kind of have to work with the surgeons, because you want them to call you back for business too.
Jerry?
I'm a little concerned about not doing an EKG if you're not familiar with that patient's EKG from prior experience.
Sure.
And I do medical legal work, so I'm called to see the cases where they didn't survive. And then in retrospect, when you look at the post-mortem exam, you would say that it's obvious that the EKG would have been abnormal had you done it.
That's fair, but the guidelines are really based on the studies available. And right now, definitely if there's any suspicion, if a patient has any risk factors, if they're a diabetic, if they have vascular disease, if they have had a stroke, I think those are patients who you should get an EKG on. But I think if we take all comers, I don't think all comers, everybody needs an EKG, but certainly patients who are higher risk, and any risk, I think, for coronary disease should get an EKG. It's very easy to do. I agree that for the most part you should, if you have any suspicion that they have something underlying. But I think they're talking in terms of the general population, and these are patients who we're not seeing, patients who maybe need cataract surgery, or patients who are undergoing superficial surgeries, maybe a young person who's undergoing an appendectomy, don't necessarily, that the EKG in and of itself is not necessarily going to predict the intraoperative and postoperative outcomes for these patients. But yes, by all means, you do make a very good point.
All right, in the interest of time, I think we'll start to close up here. But again, we'd like to thank Dr. Naib for an outstanding lecture.
Thank you so much.